Thank you very much, Neeta, Anup and Satish for inviting me to talk here. I'm going to share my experience on how I've been going about trying to improve the outcomes in lipoabdominoplasty. This is a problem that we frequently face. Women in the middle ages post-pregnancy having an abdominal bulge, love handles, pendulous aprons, pear shape. But this is what they want. They would like to have a flat-toned abdomen, no love handles, no pendulous skin, no bulges, and have a good curvy figure. To be able to deliver that, over the years, we have been addressing this problem with liposuction for grade 1 liposuction and maybe a little bit of skin excision called as limited for grade 2, grade 3, and then grade 4 are the ones where there's a lot of skin laxity, and we earlier would do only an abdominoplasty, and liposuction was fairly limited during those days. If a woman has a BMI of less than 25, an abdominoplasty should be able to give you a fairly good result when you look at them from the side, and if they have a good muscular structure, they should be able to get a flat-toned abdomen. But if the BMI is above 25, just an abdominoplasty does not address the flanks, nor does it address the horizontal laxity, and it does not address the epigastric fullness, and there is a need for liposuction felt. But liposuction, when combined with abdominoplasty, started having disastrous consequences. There used to be a high incidence of suprapubic dehiscence and suprapubic necrosis. Hence, Hugo studied the blood supply of the abdominal wall and described some safe zones. And safe zones were again kind of reinforced by Matarasso, and the periphery or the green zone was considered the safest. The yellow was the intermediate, and the SA3 or the epigastric region was considered to be an unsafe zone for liposuction, where it was advised that you should limit your liposuction in this area. This is what I trained with, and this is what I started following in my early days. And this is what I would get in India with women with a lot of fat in the epigastric region. When I limited my liposuction there and did a tummy tuck, I ended up with patients who still had a fair amount of fullness in the top, in the epigastric or upper abdominal region. And that left them with, sometimes I would also get suprapubic dehiscences. Skin necrosis was rare, but erythema or fat necrosis and evidence of poor vascularity in that area. These were issues from all the fat which was left hanging on the undersurface of the skin and kind of deprived of good blood supply. The incidence of unsatisfactory results was high, and the patient's satisfaction was low because they still saw a kind of a shapeless or barrel trunk. So I changed my technique in 2008. I had introduced laser and power assisted liposuction by then, and this is the way I did the liposuction. I can't show my laser pointer from here, but let's see if I can get a pointer here. The vertical markings, those are the areas where I would only do deep liposuction, and the crisscross or hatched area was the area where I would do quite extensive, deep as well as superficial liposuction, and then take them off for skin excision in the lower part. So currently I ask them whether they would like to have just abdominal shaping, or are they seeking to have their body reshaped or improved. If they say abdominal shaping, then I do a lower back liposuction of the hip, flanks and abdomen as well, and then do either a mini, modified, limited, or a full, or even a near circumferential abdominoplasty as the case may need. If it is a body shaping case, then I start with reshaping the butt. I would do a reshaping of the butt with fat grafting and liposuction of the upper back, lower back, along with all the other areas, and then end up with whatever abdominoplasty that is required as per the laxity of the skin. The sequence of procedures, if it's abdominal shaping, is I start with liposuction of the back and hip with the patient in the prone position first. Then I turn the patient side to side and do a flank liposuction. Then turn the patient supine for an upper abdominal liposuction and then finish off with the abdominoplasty. If it is a body reshaping procedure, I start with liposuction of the upper abdomen in the supine first, then turn the patient side to side for flank liposuction, then turn the patient prone for a lower back or a hip liposuction, and then through the harvested fat inject it into the buttock, then turn the patient supine and finish off with an abdominoplasty. All along, I do only limited undermining when I'm doing an abdominoplasty, and it's the green central zone that's undermined, around 8 to 10 centimeters in the midline. The other area, as you see in the left, is discontinuous undermining done by the liposuction itself, and it's not kind of freed to maintain the vascularity of the upper abdominal skin flap. I used high lateral tension closure, which basically consists of using ethibond or non-absorbable sutures for the superficial fascial system, so that a lot of tension can be put on the skin and none on the skin itself. This is a picture on the left before the liposuction and fat grafting, and on the left side the fat has been injected in the buttock and the hip and lower back area has been liposuction. An appearance from the side view of how how the patient looks after the fat has been injected into the buttock. And a few cases here. This is a lady who had a BMI of 33, extensive divarication and an umbilical hernia, and a scar from the previous cesarean. And that, this is after extensive liposuction, correction of the divarication, and this is a three-dimensional liposuction. So even the lower back and the thighs have been liposuction, as you can see from here. So quite an extensive amount of liposuction was required, and then finished off with an abdominoplasty in the same setting. Another case with lots of stretch marks, lots of laxity in the skin, definitely needs an abdominoplasty, but a lot of fat in the upper abdomen and the lower back area as well. So without liposuction of these other areas, she wouldn't get the kind of result that she desired. And a similar case where the upper abdomen has been liposuction, the flanks, the lower back. This is the case who only wanted abdominal improvement and a breast lift at the same time. So this has been corrected. Still, she has a lot of intra-abdominal fat, wasn't able to give her really a scaphoid abdomen. But the back has improved considerably by the liposuction. She subsequently had upper back and even arms liposuction in a staged procedure following this. If the BMI is not so much, but the laxity extends into the flanks or even into the lower back, do not hesitate to take your abdominoplasty circumferentially or near circumferentially. And then you can combine it with liposuction, as seen here. The areas in the upper abdomen and the flanks were liposuction, and the abdominoplasty with correction of the divarication has given her a nice taut abdomen, and the excision of the abdominoplasty skin extends almost to the back, not all around, just about short of circumferential. Unfortunately, the scar just migrated up a little bit, but she's had a fairly good improvement in the waistline and the tightness of the skin. We often get patients whose BMIs are 38 or plus, and these patients, despite telling them that maybe they should go for bariatric surgery, they are totally against that, and they ask us to help them with whatever we can. Plus, we have to try to deliver as much improvement as you can in one setting itself. So liposuction of the, as I said, was started from the lower back, hips, and then flanks and the upper abdomen, and then they finished off with an abdominoplasty. Even the inner thighs were liposuction, and that's an area where they do end up with a little bit of laxity in the skin, but they can be suggested a thigh lift as a secondary procedure. and they get a considerable amount of improvement, a huge amount of fat reduction as well, and an improvement in the figure which they are fairly happy or satisfied with. If you have saddlebags, liposuction of this would lead to a lot of laxity in the skin in this area, and it is better combined with an abdominoplasty. She had an abdominal divertication as well, and that was corrected, plus the thigh skin, which was loose after liposuction, was lifted up with a near circumferential abdominoplasty. So this abdominoplasty extends way to the back, but it has corrected all the saddlebags, and the liposuction has reduced or given her a fairly good figure as well. Post-abdominal hernias, if they are left untreated, just taking away the panniculus is sometimes not adequate. Extensive liposuction of the upper abdomen, the flanks, the lower back, even the upper back in this area, in this patient, and correction helps them in getting a figure that they would be happy with and not have to come back for surgery. Again, extensive liposuction of the saddlebag area and lifting it up in a near circumferential abdominoplasty. Lower back, upper abdomen, even the thighs have been liposuction, and the buttock has been shaped with liposuction alone. There wasn't any need for an injection there. But this lady came for body improvement. It wasn't just an abdominal improvement. There's hardly any excess skin on the abdomen, and we started with liposuction of the anterior abdomen, the flanks, and then injected it into the lateral point. You can see that her figure has become curvy. If you see her from behind, the depressions that she had has been taken care of. Fat has been liposuction from here and there and injected into her buttock to improve her figure. Same problem in this case, depressions on the side, a figure that she didn't like, a little bit of laxity in the abdominal skin that was taken care of, and the fat injected into the buttocks to improve the figure to a more curvy appearance. This is a fairly reliable procedure. It does increase the operating time, but if we take all the precautions as Louise has said, warmers, the calf compression pumps, and all the intraoperative precautions, I prefer to do these under epidural anesthesia, so that post-operatively you can continue with the epidural subsequently. Keeps them absolutely pain-free, and the drains come out in a couple of days' time, and that helps in early mobilization of the patient too. So same thing has been done here. The fat has been injected in the buttocks and the zone 5 or zone C in the lateral side to give her an improvement in the curviness of the figure. You can see the fat grafting which has survived, and it's improved the buttock projection as well. Post-bariatric patients need a lot of liposuction as well. Sometimes they get stabilized at a higher BMI. You have to liposuction them. It's just not just taking away all the excess skin. So you liposuction, and you can use that fat to inject into the buttock. The other alternative is a flap, as Louise had shown, but you can add the fat through fat injection, which is a simple procedure, and improve the buttock projection and get rid of all the laxity as well at the same time. Despite all of this liposuction and tummy tuck, there has not been any major complication. No skin necrosis, no hematomas, no fat necrosis, no erythemas. The only issue we had was seromas, and I think seromas is a dog ears in 1% of the cases. Pigmentation sometimes, again it's because of the vasa. Scar hypertrophy or stretching is an issue if it's under high tightness, but over time that also fades away. So liposuction is important for a good result in high BMI patients, and liposuction with vasa does not harm the perforators. Uniform deep liposuction is possible. Liposuction plus fat grafting helps in delivering a better shape when combined with tightening procedures. And there is a need to look at the whole of truncal region rather than just the front of the tummy for better patient satisfaction and better aesthetic outcomes. Thank you.